Hey everyone, this is Rebecca Seagraves
Jenna Seagraves.
and we are joined by the wonderful Dr. Allyson Sutkowi-Hemstreet. And I've been looking forward to this. And Allyson,
Yes.
thank you so much for joining us.
I'm very happy. I'm very excited to be here. Thanks, y'all, for joining us. I know it can be hard to jump on a Zoom call after official work hours.
Absolutely.
Yes.
With your kids who can emerge from the bedroom at any
At
point.
any moment.
Send me many good wishes.
We'll
Hopefully, no
we'll try
small
not to
people.
get too rowdy, right?
Right.
Allyson, I want to start out talking about an opinion piece that you recently wrote for the APTA magazine. But there's a quote. I want to just kind of hit the ground running with a quote. And I think Jenna has about 12 quotes, but I'm going to start with mine. Mine is a little bit short, but we're going to just have this conversation around and wrap it around a quote that I still am thinking of ever since reading it. So you wrote, and let's give a little bit of background about this piece. How would you say, what was your main goal for the piece that you wrote for the APTA magazine?
Well, so I think it was, I think I had a few goals with it. And this is something that I've thought about a lot as a student, as a new clinician, as a more experienced clinician, is sort of how do our identities impact our patient care? Because especially in a field where we connect frequently and sometimes with a higher level of emotional intimacy in rehab than we do in some other, like the healthcare settings. Um, and I've just always had this sense that oftentimes when we're talking about the LGBTQ plus community, we're talking only about patients and we're not necessarily talking about our colleagues or the people that we interact frequently with, other healthcare providers, family members, things like that. Um, and it was just really important for me to add this perspective to this idea that it's not all just about deficit, that there can be positive benefits to being authentic in the spaces where we work. And sometimes I feel like my authenticity and my fluidity is almost like my superpower in the clinic. It's not something that I feel awkward about. It's not something I feel ashamed about. I think it just helps me really be myself in all those different ways and feel open to doing that. And yeah, I wanted to put it out into the universe, especially for people who are maybe newer or students who are thinking like, boy, how can I really show up in these hierarchical clinical spaces? Especially at like predominantly white, more buttoned up conservative institutions. Can I really be myself in those spaces? And my vote is yes, mostly.
Our vote is yes too.
Okay.
Absolutely. The quote that got me completely like, wow. I mean, just the whole article, really. I mean, Jenna just showed a full page of everything she wants to
Basically,
talk about.
the entire article.
But one of the things that you said was enduring the recurrent scrutiny of the public eye in my androgynous pregnant body awakened me further to the experiences of people who move through the world with amputated limbs, staggering limps, and conspicuous scars. It is not the same experience for many reasons, but unwanted attention towards one's physical presentation is draining and distracting. Wow.
Tell me why that resonated with you.
Whoa. Oh man. All right. So not many people know this about me, but I'm a woman of color. And I often have to kind of deal with yeah, and of course I'm absolutely joking, but that's kind of just in terms of the places that I've chosen to live because I love hiking, I love mountain biking, I love outdoors activities, but you don't see a lot of women of color or people of color engaged in. And so I've lived in anywhere from Appalachia to very rural, underserved areas. And there is just one rule that I've always asked Jenna, to have is that we don't disclose our marital status. And so up until recently, we've just chosen to not work in the same environment. come 2020, we didn't really have that choice. We were actually working at the hospital where I started services for women after birth with a team, and Jenna was part of that team. So we really casually just kind of circumvented the, yeah, you have the same last name. Tell us what's that about? Are you sisters? And so it's just been kind of just easier to just navigate, even in professional spaces, you know, just the uncomfortable truths of either our profession or either the work that we do. We work with women who have had babies. And so not only do we get questions as, well, you've never had a baby, you've never experienced birth, you know, are you qualified, you know, to talk about this? Or, well, you're in a homosexual relationship. Are you qualified to talk to someone who's in a heterosexual relationship? And you're a pelvic health therapist, you know, should you be doing women's health? I mean, so it's kind of been distracting from the professional work that we've done, from all the gains that we've made in terms of the help that we've given to people, to be also considerate of, well, you know, am I making them uncomfortable with my very presence, right? That's a lot as a clinician to have to think about. And in addition to the work that we want to do to reduce and to completely eliminate, you know, the obvious preventative challenges that we have that's affecting the maternal health crisis, that's contributing to it. And so it's distracting with the work that we've chosen to do, but we need pieces like yours to remind us that, you know, as much as we think it's distracting, our belonging, right, in this, in what we're doing is just set in stone. You know, we're building such a foundation, such a team, such an awareness that there is no apology for our existence. There's no room for it. I make no room for it anymore. I don't speak for Jenna.
Yeah, I mean, so I think it's apparent that the piece really, really spoke to me. I like took all of it and was like, oh, this is great. I'm going to take this. And then I realized I'm basically taking her entire piece and just putting it on a Word document and saying that these are all the points we need to talk about. So let's just go paragraph by paragraph. But no, it was, for me, it was just so, I think, wonderful to read and to hear another voice who is truly being as authentic as you are. And it read through the work that you did. I mean, it was so apparent that you really put a lot of work and thought into not only the piece that you were writing, but just, you know, in expressing to everyone that you are being true to yourself at all times. And that for me was a really great reminder, because you had a section in there where you talked about not everyone who is part of the LGBTQ plus community will do that or will feel safe to do that, and that you also respect that, you know. And for me, that really was a big part of my life, my career, and it's still something that I'm navigating, where sometimes I choose not to disclose certain parts of my personal identity, my personal life with patients, whereas others I will. And something that I'm going through with my own individual journey is that I have found that when I am true to myself and I don't, you know, hide it, it does end up being a better experience. But it's hard. Sometimes it is. It's really hard, because I do fear the negative response that I have gotten in the past, and I don't want to relive that. But I do think that trying to stay true to myself really will have better outcomes for both myself and the patient. I mean, I could start quoting you to say like this, you know, really, really hit me. But really, I just thank you for even writing it and for allowing others to be able to read it.
Thanks.
Would you be willing to just kind of share that experience? So, you know, just even from the standpoint of just being pregnant, right? How was that for you?
Yeah, so So I ended up carrying both of the children in my family, and sort of extenuating circumstances. I was always like open to it, but we um, it's just how it played out, and it felt in some ways very simple. Like I didn't have too many problems with it. I had healthy pregnancies, but it really pushed me into confronting a lot of the ways I felt about myself, my identity, my body, and some of the ways that I would present at work or out in the world. Like there's not a wide variety of maternity clothes that falls into more androgynous presentations. There's a lot of ruffles and bows and things that it was not my vibe. So that was honestly challenging. It was challenging just to dress myself and feel like that, um, that like all of my different energies were present and accounted for. I ended up just feeling like very feminized by my body. And that was interesting. Especially working in acute care where we're like physically close to patients, like I would have to help transfer someone. I would be like, I'm gonna put my baby in your lap, basically. Like, so there was no way of avoiding that because it was part of my sort of daily activities once I was visibly pregnant. So yeah, I wrestled a little bit with dressing myself with like a little bit of just dysphoria. Like my body had always been much more like athletic, and this was very different than what I was used to. Um, I was not used to people making so many comments about my body and about my appearance, and like the unwanted, like, oh, can I touch your belly? I was like, no, no, I'm not. No, thank you. Like, I'm not into that. Very nice, well-meaning people, but I had to um, be okay with my personal boundaries around that. Yeah, I think one of the biggest, most interesting things for me, so like I've had short hair and sort of masculine of center dress since I was in my early 20s. And I wasn't pregnant till about my mid 30s. And it was like I got a free pass into the girls' club. Like people at the hospital I worked at who like had never spoken to me. I
Wow.
Yeah.
They were like, "Oh, you're totally non-threatening now." Like they were totally it was just bonkers. They like wanted to talk babies and pregnancy and all the things. People were very friendly to me when like nothing else had changed except that I was pregnant. So that was just really interesting to me, to just see how much people um, like categorize me differently in their brain, where they're like, okay, you're on our team now, like you're a girl for sure. It's like I've always been a girl. But okay. Yeah,
Right.
just like maybe more than you wanted to know, but
Isn't it
I had a
interesting?
lot of feelings about it.
No, I love hearing about feelings. Feelings are my favorite.
It's my better half. Isn't it interesting how all of a sudden I don't know, we're just more accepting of people who fit into our ideal identity of them, right?
Yeah.
And maternal health to me, I speak about this. I get people into these rooms and into these spaces to speak about mental health, really.
Mm.
Health is mental health, and just health in general is mental health. And so in terms of just the mental health of just what you're saying and what you're describing is that you were treated like a person once you became pregnant by, at least by that subset of people at your workplace.
Yeah, I mean, like people had always been like kind and friendly to me, but it was like they had a better category for me. It's like existing in these sort of like liminal spaces where people are like, I'm not sure what's happening with your gender, I'm not sure what's happening with your sexuality, but it was like, okay, you're going to be a mom. Like now I know where to put you. And like whatever, for whatever reason that like let their guard down a little bit and just connect with me. Because I wasn't any different. It was like there was, I don't know if it was more common ground or if there was just less confusion about like which box to stick me in. It was just interesting.
What I find interesting, and so this is no secret, Jenna and I teach a course, and we're actually leaving tomorrow night to fly out to Virginia to teach a health system of 7 different facilities, I believe that we counted, of OTs and PTs who work in the hospital. And we are bringing the course on starting a PT, OT and PT program, right, in the hospital to this health system. And there are just things that I don't think about including in the course, but there's an experience that I have that just kind of like resonates really well with what you're describing. Two experiences actually, where I treated a person after a cesarean section in the hospital who identified with the pronouns them, they, and in the room in my presence, both times, both occasions, different people, mom, she, her, just no, you had a baby. I'm going to ignore even, one person even went so far as to actually put it on the outside door where, other, individuals were putting their baby's name and just kind of like the cute little thing of like how much, their baby weighed. And just so you had that information, they actually took the time to, let people know before you come into the room, my preferred pronouns are such and such. And to me, the setting that I wouldn't have to think about, I would think that I wouldn't have to think about including in this education would be the acute care environment where we are trained to see anyone who comes through the door and just respect how they identify. And it just kind of floored me working on the maternity unit. It's not that I had all this experience as an acute care therapist, but just working on the maternity unit was just like, really? That's kind of blatant, in terms of just disregard for their health, their health care.
Yeah, it's really interesting. And I think in many of those situations, I didn't interpret any of those sort of interactions where people made a lot of assumptions about me. I didn't imbue them with like malice in my mind, but I think there is a lot of room for us to improve, across all healthcare providers, especially in the maternity setting.
That's such a nice way to put it. Room for
Very
improvement.
polite, very polite.
Yeah. Like, so you get a lot of appointments when you are pregnant, right? If you do all your prenatal care and then you have the baby and then you go get checked out afterwards and pediatricians and all that, right? It's a lot of interaction with the healthcare system. And out of all of, especially for people who, may require scientific assistance to get pregnant, it's just a lot of healthcare. And I had one person ask me what my pronouns are, but through 2 pregnancies. So it's like tons of people. And I had some really like wild experiences where like we would go for a prenatal appointment and I would sit up on the little table with the crinkly paper and my wife would sit in the like other person chair, and they would like people would come in and start talking to her, and like I was like, excuse me, I'm pregnant, and they would be like, oh, like hold on, let me back up, like just my wife is more feminine appearing than me, and they just, I don't know, that it was just, again, like not malice, like nobody was trying to leave anybody out, but just not ready, not thinking about like, how can I be inclusive in how I approach this family? How can I be inclusive in my language? Those are easy, low-hanging fruit to just be more inclusive in your practice.
How would you, what would be your recommendations for others in healthcare to be more inclusive? just for everyone who's here listening, and for others that may listen to this later, what would be, you know, at least one piece of solid advice that
I mean,
you
just
recommend?
one. Like I'm
Well,
dying here.
you could give us a list. Look, I love lists. Okay.
I have so much to say, but we're interviewing Allyson.
That's right.
Yeah, I think there's lots of low-hanging fruit in this area, like inclusive forms. Yeah, thank you, Noah. Says that Noah
I have
has a whole bunch
lists.
of lists. I'm like, you know, let's propagate that, right? Like if somebody is doing this already and doing it well, then like, you know, it's probably 90% of the way there, and let's pass it around. Yeah, I think inclusive forms, inclusive language, open-ended questions about family relationships, and then just doing your own work, like read about people whose lives are different than yours. You know, you're gonna see all kinds. You're gonna see polyamorous families. You're gonna see all kinds of blended families. I don't know, big age differences. Just say, tell me who's in the room with you. That's easy.
Yeah.
You can start.
Exactly.
Yeah, that's
Tell me
great.
who's in the room with you. That is such a
That is
welcoming, open door question,
Mm-hmm.
you know, or statement. I guess the reason why I feel so strongly, and I'm just a little bit more just like direct at, you know, just this whole thing. When I again, coming even from a mental health standpoint, right? I had to switch gears. I have a cardiopulmonary clinical specialist on the show, and we're talking about, you know, probably something that, you know, you would think in terms of the maternal health crisis, we should probably be talking about heart health.
Mm.
But as of last year, around this time, read a report, and now that's becoming a lot more apparent in discussions, is that suicide actually is the leading cause of pregnancy related death up to the first year postpartum. Suicide. And so when you're thinking about when people tell you they've lost their identity during pregnancy, immediately postpartum, think we could do a little bit more work in terms of helping them recognize, find that, or honor the identity they at least want to have, want to maintain, want to retain. That's to me, that's on the ground. That fruit has already fallen off the tree. Just pick it up.
Can we talk about that ahead of time? Are those topics not things that we can cover well before a baby arrives? Right? Like, how much information does a person who hasn't slept worth a hill of beans, or they've had their body, you know, ravaged in some capacity by having a baby? It's crazy. And there's like crazy hormonal changes. Like, that is not right. Like, as PTs, we think a lot about when and how are people receptive to learning and what kinds of teaching is going to be appropriate for them. Well, that's not the time, right? That train has left the station. You can give them all the handouts you want, but if somebody hasn't, you know, is literally going to go home and have a month or 2 or 3 or 4 of sleep deprivation, right? Like,
if they're not already, right?
yeah.
I mean, we could walk into a room and we would hear that person hadn't slept for 4 days before, whether they were in the hospital, 3 days of labor, and it finally just either happened, or they had emergent, you know, C-section or whatever. Not at all the capacity, not at all on me to ignore the sign that they somehow mustered up the courage to have their family put on the door in terms of how they wanted to be identified. Really, like their cup was already, they were already tapped out. The least I could do was to come into the room and try to involve them 100% in their care. That was the least I could do.
Yeah.
That was the fruit on the ground that I'm talking about, that we could just pick up, not even low hanging. That's the least that we can do, first of all, for those individuals.
Well, and I think, you know, this might be sort of a loose thread, but like when we're talking about affirming people and recognizing their lived experience and their family, and, you know, celebrating this new life with them instead of making them feel like they don't belong there, like that is not only mental health, that is also taking care of people's hearts, right? Like when people are chronically stressed in these very taxing environments, like one person can make a big difference. Like one person treating you right and listening to you and monitoring you closely and really attending to how you're doing both from a psychological and from a physiological perspective, like that matters. That's not small potatoes. And I don't think we, as a profession, we should ever let anybody feel like it is. We can do a lot of good in a short period of time. And that's like what I love about acute care.
And that's actually pretty heavy.
Mhm.
So you just connected treating people, engaging with them, to the stress on their heart.
Yeah. Those eyebrows.
Can you just, yeah, just can you
Do
tell
that
us a
again.
little bit more? This, I mean,
Well,
deep.
I mean, like that's, I don't know, that's not new, right? Like we talk about chronic stressors and their relationship to cardiovascular disease all the time, but like, why do you think people in the queer and trans community, why do you think people of color in America have like, you know, statistically worse heart health? Like, I mean,
Oh, because their health
Wow.
literacy is low.
Wow.
They're
oh,
clearly.
That's the only answer.
and because race is obviously a biological construct. So, you know, that was a joke for
For everyone listening, yes.
just to clarify, was a yeah, questionable joke. Okay, race is a social construct, right? Nobody has bought themselves worse heart health because of their racial identity, racial and ethnic identity. That's not how it works, right? People are
Right.
Yeah.
chronically and deeply stressed from, you know, from before they're born, right? Like
Mhm.
Yeah.
the stress state of the person carrying that baby affects the well-being of the child, right? Like that's one of the many tentacles of intergenerational trauma, right? Is that the external stresses impact our internal state.
Yeah.
Amazing. Little personal history. So I'm the youngest of six. And I've been a lot more transparent with this, but my mom had been in and out of mental health institutions, um, you know, in her 20s. And it's very just interesting in terms of just learning more about my own family history, because we ask
Mm,
people, we kind of invade, you know, their history and just kind of take from it and assign it a category all the
mhm.
time, you know, actually within the first 7 minutes of meeting them. And so I thought, you know, let me do a deeper dive, you know, onto my family history. And there's a lot, you know, with regards to just mental health that I'm now like more aware of, talking about, you know, just different things a lot more. But being on the patient end of that, labels are so scary to me, right? To actually like put myself in that, you know, in those shoes, because as a health provider, I know what it looks like on paper to have a mental health history.
Yep.
And so it scares me to think, wow, we do this and we don't even think about it anymore. We say we're trying to improve health literacy. And I said, well, what measure are we using to determine health literacy? Is it the paper that we've just given somebody with all the instructions and we're expecting them to like read it, conceptualize it, understand it. And then if they don't, their health literacy already drops like 10 points. Like what standard do we use to determine that someone, you know, is aware of their own care and is involved in their own care? And, you know, yeah, to me, all of it
Yeah,
is distracting from the elephant in the room, that we
agreed.
already have the standard in our minds, you know, and if you don't meet that standard, then that's how we categorize you. We've already created it.
Yeah. Yeah, there's so much, I think there's so much that, you know, gets us, that relates to some of these topics, you know, whether it's bias in medical health records, you know, how does what is listed in someone's past medical history, how do people sort of carry that forward, and you know, discussions of non-compliance or, oh, you know, the patient stated you know, what are you quoting? Why are you quoting it? How do those issues get sort of propagated forward through the EMR? Those things can be really problematic, among other issues of, you know, how do we determine someone's health literacy, and, you know, does it really match up to our white supremacy culture standards of what health literacy means? Well, I don't know.
Right.
There's really a lot of it's probably not a fair concept for every person that comes into the hospital.
Right.
Have you really investigated like language barriers? Yeah,
Right.
maybe
Exactly.
a little sidebar, but
It's not a sidebar. No, I mean, so like even in just like preparing for this talk with you, right? I, have to recognize, we're right now in a very deep, discussion about protocols that are used to determine if someone's blood pressure during pregnancy is way too high. We're in a deep discussion about eclampsia, preeclampsia, hypertension, what it means to be an athlete. And, I mean, I just would be remiss if we actually didn't talk about, these issues that are just so, to me, current, the current state of healthcare, right? And just to even mention, Tori Bowie, who is a 32-year-old Olympian who passed away on May 2nd, and was found by an autopsy to have died while in childbirth of respiratory distress and eclampsia. And one of our co-speakers that will be joining us with you and Jenna, myself, Dr. Catherine Sylvester, I remember talking with her just a few days ago, and she says, you realize that means they may have missed that she even had preeclampsia. Right. And so to me, protocols, health literacy, I'm starting to question everything days before I'm teaching a course, which is great, throw all the literature out the window. Because I'm going to teach the standard is 140/90 is hypertension, is high blood pressure. But if you're an athlete and you're resting at 100/70, what does that mean for you if your provider is waiting on their protocol?
right. And like, does that really encapsulate, like, well, looking at what's typical for an individual versus like for one specific individual? I think it's absolutely fair for us to be interrogating some of these standards, because like, no matter what, we can always get back to this place where maternal health care in this country is deeply, deeply inequitable. It is deeply flawed, right? And like, this is a problem every day in this country. People are dying, people, and like, we have to do better. So like, it doesn't matter if somebody feels really passionate about that 140/90. Like, that one, that's why we are taught to think critically and assess literature critically. And two, we use our clinical reasoning skills to say like, well, yeah, okay, 140/90 is pretty darn high, but like, look at the individual in front of you and make some clinical decisions about, oh, I'm surprised to see you're in the 130s/90. Oh, like, that's creeping up. I wouldn't expect that for someone who's a superstar track athlete. Right. That's a missed. That's probably a miss when we rely too heavily on like strong cutoffs and less on just reasoning and thinking about individuals.
Right. I think Jenna kind of blew me away. She does, like, to me, the fact that she's a neurologic clinical specialist, that just doesn't mean anything in terms of like what patient population she's advocating for, she's treating, any of that. Like, she just has been able to just really flow in and out of so many different settings and so many different people that she's worked for. And she catches things like way before I even think of it. And we were having a conversation this morning because of a text message I got from same person, Dr. Catherine Sylvester, and she was trying to like understand just from a physiological standpoint, you know, when someone has just given birth, their circulation is very dysregulated up to a week or even 14 days, at least, you know, that we have in the literature. But then what does that mean in terms of like what that's doing to their organs? What is normal for them? What was their baseline? And so just from your like standpoint, I mean, there's a case that comes to mind where she unfortunately treated on the back end an individual who rushed to the hospital, was readmitted for a brain bleed just because, you know, things were just missed. You know, she might have been up walking, passing gas. And on the side, this individual actually was really Caucasian, just something that you would completely miss. And I just realized, you know, this crisis, these health disparities, they're affecting everyone because either you're put into a box where you're either not literate enough, or you're just given the bare minimum to not overwhelm you, or you're put into a box that says you're a-okay. You probably have support at home. And this person actually ended up being a single mom of two other small children she had to care for, and then having a C-section with the one. And it was just like, all of us do it. We do it to each other. We're just, it's almost like my course or any course in PT practice, healthcare providers should just start with identity training. Actually challenging our own thoughts on identity. Like that's where we really should start, is let's challenge our own thoughts on identity, because it is affecting people. It's affecting the healthcare that we're providing to people.
Yeah, I think there's two pieces there of like, one absolutely is that fall under, you know, non-negotiable parts of, or what should, in my opinion, be non-negotiable parts of our professional development, which is interrogating your own biases and just recognizing that like the water we swim in is poisoned, you know, with racism and all the other ableisms. Like we live in a very our culture is not where it needs to be in terms of just including all people and valuing all people's experience. So 100% yes to that. And then I think that's another sell for people who like start to feel squishy when people are talking about DEI. They're like, I don't know, you know, like this doesn't really line up with this. But like for me, when I want to talk to people about why DEI matters to everyone, is it's really like the point is equity, the point is high quality, and the point is that this is good for everybody. It's not so focused on just one group of people or one type of diversity. It's really like, how can you build something? It's the equivalent of universal design, right? Like if you can build something that the most number of people can use in the best way, that's just good design, period. And we can think about our practice that way too.
Noah, thank you for saying this.
Noah.
Week 1 PT school, this should be discussed before anyone touches my body or when I touch someone else's body. That is so true. Take off your shirt, sports bras, you know, or not, shorts, and we just start palpating.
There are programs who are taking that on.
Tell us about it. Like what does that look like? We're both assistant professors at a you know, PT program. We would love to know what other programs are doing.
Yeah, so you know, in the last couple of months, I've been able to talk with a lot of different programs about what they're doing in terms of you know, my residency's coming to an end. I'm interviewing different places, and it's really interesting to see that there are some programs who have really deliberately started their curricula with classes that address some of these big sort of DEI topics, trauma-informed care, consent, bias, racism, ableism, sexism, homophobia, all of the isms, like they are trying to, lead with that.
They
Imbue
start
it.
with that? That's like in
Yeah.
year 3.
I think
No.
it's great to start with that. It
Yeah.
helps you within your own cohort. It helps
Yes.
anytime they do integrated clinicals. Sorry, I didn't mean to cut you off, Allison.
No, yeah. So yeah, starting with it and then trying to have a thread of it and then also tying it back together after people have had experiences in the clinic. There are a number of programs that are very being very deliberate about that. And I think that is one really good for patient care, but also, I have learned so much and I am so grateful to some of the students at Duke who have been just open and vulnerable and willing to talk about things. We make this assumption that when we perform trauma-informed care and we try to build that into how we teach and how we ask the students to operate, and it's not just for the patients, right? We have students who have undergone serious trauma, and we cannot have our classrooms operate on this assumption that everybody who's in the room is privileged and who's never gone through anything terrible. Like that just doesn't even make sense statistically with the number of people who are subject to sexual violence and abuse. Like that is just totally bonkers that we still operate like that anywhere. So I think, we got to stop just talking about patients and really this is for your whole cohort. This is for your peers. You can be doing harm to each other in PT school if you are not acting right in the classroom.
Have you ever heard, you just have to toughen up, sometimes you're just going to get tough patients? As a student, I abhorred that. I felt like, wow, like this sounds like a sentence. Like you're a healthcare provider now, toughen up, just take abuse. And it's just like, we focus on the patients a lot, as we should. We forget at the sake, we compromise our own health in doing that. That just goes against the whole oxygen mask principle. It's just throws that out the window.
Yeah.
And, thinking about it in our profession, like who is doing the education is not always reflective of the patients and it's not always reflective of the student body. And to send that message to groups of students coming through or new trainees who have completely and wildly different identities and different lived experiences than the people dispensing that advice, that's a no, right? We should be talking about how do we set appropriate boundaries? How do we interact with people who are misbehaving in the clinic? Because each of us three, each of our experiences in interacting with people who are not acting right in the clinic is going to be really different. And it's going to be triggering and traumatizing in different ways if we teach people to just say, yep, come work in healthcare and be abused by anyone who you don't put your foot down with. That's not, no. It's a no for me.
We definitely have a little bit of I would say a controversy in our household.
Where's this going?
Well, so here's the thing. So we talk about this a lot. No, seriously. Like we just talked about this recently. And I said, I would rather want to know if someone's uncomfortable with me, right? As a healthcare provider, I'd rather want to know who that person is so I can avoid care from that individual. And that is controversial because, DEI, obviously, even on PT programs, it's actually defined. You can take things out of your statement.
This is true. Yes,
right?
you can.
And so, because you are in the faculty residency at Duke, right? And so you are probably on the hunt right now for a faculty position. And if you read closely in that disclaimer of just who's accepted, you will find that some schools can choose what they put in there and and I say, well, that is absolutely fine with me. I wish healthcare providers would do the same so that we can avoid them like the plague. But I know Jenna
feel very differently from that.
I would love to hear your thoughts.
Well, to me, that So my opinion is that goes completely against everything that we're really trying to do in terms of providing equitable care for all, including care for ourselves as patients, but then also to all patients. And so I do believe in all of the DEI initiatives to be, embrace diversity, but to also have inclusivity, to provide, students, but also patients, clients, colleagues, everyone with equitable care and compassion. And so for me, I think it's important that we educate, because we are professors, so we do teach students, but we also work with a lot of different clients from various backgrounds. And I want them to feel comfortable with me, regardless of where they're coming from, regardless of how they identify, what their background is, because I want the best for them. And and I want to teach, I want our future generation of physical therapists to do the same. I want them to be able, whoever comes into your clinic or whoever you're working with in the hospital, that is a person. That is a person that you are working with. And you need to treat them like a person. And so for me, it's just interesting because this is something that we are actually fairly divided on, because Rebecca would prefer to have a provider basically state, look, I don't feel comfortable treating Black people.
I would love that. I don't feel comfortable treating Black people, who identify in the LGBTQ. I want to see them coming, right? I want to know. I live in rural areas, right? I mean, I've lived in big cities as well, but a lot of my community right now is very small. And I'd like to know who to go to and who to avoid. Because if you force everyone with DEI, you could be getting care from someone who does not have your interests, at heart. And for me, that transparency is so important. And so, yeah, there are PT schools if they're, Christian based or faith based, and they don't necessarily accept the LGBT community. For me as a student, that's important information to know.
Yeah, so, and I think you can approach that issue whether as a consumer of healthcare, a student, someone who's looking for occupation. I think you can approach it, either looking for indicators that this is not a welcoming place or they don't prioritize equity, or you can look for sort of signals on the other end. Not just like, yes, we support it, like some blanket statement, but like, okay, well, show me. I've had the privilege of working with Tiffany Adams, who is our DEI leader at Duke, who's like totally amazing. But one of the things that she says a lot is like, well, basically show me what has been impactful. Like, in what ways have your values shown up in an impactful way? Show me the output, show me the product of what you've been doing. Don't just give me the lip service. And I think that is a much different question than like, well, tell me what is your stated value around equity or something. That's an easy question for many people to answer. But when we start interrogating the impact of actions and where you put your resources, you might get a different sense of how do those values show up in action, I guess.
Right. Absolutely. What's next then in terms of what are you hoping to bring to a program that you teach? And soon, hopefully. What are you hoping to? Yeah.
Great question. I'm trying to decide, to what level of detail I want to.
Get you ready.
2 minutes.
No, right. Okay, so I think it's really important that we talk about health equity across curricula, not just in, sort of siloed classes, sort of the like professional development type classes. I think students perceive those as being like of less value than something like anatomy and MSK. So I think if we can really design curricula that really threads those things throughout. That's something I feel passionate about. I think we can really improve our clinical examination skills in terms of, you know, who and how and when do we perform cardiovascular screening, and how frequently, and sort of what is our role there? How do we make sure that our integumentary examinations are inclusive of everybody we're going to see? Yeah, so I have lots of curricular thoughts. And then, yeah, in terms of service, like I'm always going to show up for DEI because that's just where my heart is. And yeah, some of my scholarship also sort of ties those things together. It's basically cardiopulmonary health equity. How can we do better? How can PTs be more effective for trying to make our care more inclusive and more equitable for everybody?
You have put a permanent smile on my face. I'm introducing pregnancy in the cardiopulmonary content because I get to teach it.
Awesome.
That's right. And that's so just to hear you say that as a cardiopulmonary clinical specialist, that you're not just reserving, those populations, those special populations, for,
yeah,
you're right, less valued courses. Oh, this is not as high stakes is what students say. Not as high stakes. And to me, if we introduce those concepts at the beginning, it sets such a different foundation for their practice going forward.
Yeah. And like, there is no other profession that is better suited for chronic disease prevention and management and health promotion than us. And we don't always like shine there. And I think we can. And I think we need to really think about what is our role as a profession in terms of addressing some of these egregious health disparities. And I think maternal health is like, for me, that is a no-brainer. Like, where else should we start except right there? Because like the statistics are so abysmal, and like it needs multi-pronged solutions, and there's no reason why we shouldn't be a part of that. We have a lot of value to add, especially in the hospital. So big shout out to everybody who's doing this already in the hospital. You have all my love and affection and encouragement. So
absolutely. Wow. Hey, we can't thank you enough, Allyson, for joining us tonight. We just wanted a real conversation, just your perspective on all of these things, and we just want to support you going forward. We're super excited to be speaking with you. Yeah.
In Boston. Wait, Boston 2024.
Yeah, combined sections meeting. Yeah, February 2024. We've really, so peripartum cardiomyopathy is going to be our main topic, but we are going out to all settings. So we have an acute care background. For the most part, Catherine Sylvester has been doing a lot in the home setting and a lot with remote monitoring. And so just to give people a little bit of a taste, this is really going to be for all settings, but we're sponsored by the cardiopulmonary section of the APTA. And true to my nature, I'm going to include, a section on OTs. I'm just very inclusive of their practice. To me, I don't think that I really would have just been, my eyes would not have been opened up to the importance of identity and role identity and just people's value that they put on occupations they have to return to, newborn cares and ADL. And so all of those things that challenge the heart, that exceed the body's physiological capacity, those are things that I definitely, I cannot wait to kind of unpack with you and just learn from you as well.
Okay, we also need to talk about climate change.
Whoa. Okay. Came out of what? Like right at the end?
We have.
I know. Sorry.
1 minute.
Not even. Okay.
We have less than 1 minute. Give it to us, Allyson. What?
Climate change is huge, okay? And it's going to be a bigger problem. Air pollution, increased allergens. These are all things that are terrible for the heart and lungs. Extreme heat, people who work outdoors, migrant worker, right? Like, okay, there's a lot here. Health disparities, explosion with climate change. We're going to table that for another
next
talk.
webinar.
What? And she just left us with the cliffhanger.
I didn't plan it.
That's got to be our talk. Climate change and maternal or climate.
man.
Oh,
and,
that's
and cardiac health.
and cardiac health. I mean,
It's
seriously.
gonna keep you up tonight, probably.
Heck yeah, we're gonna talk all about it.
That's right. And all the babies, right?
Right.
This is pediatrics. This is stuff that cuts
Well,
across
you're
all
right.
these silos.
Oh my goodness.
Let's talk about
Yeah.
it. Yeah.
Christy with the mind blown emoji. Yes.
Wow. All right, Allison, thanks for hanging out. I mean,
Yes,
Okay, you all are awesome.
seriously,
I
no.
don't know if
you're
people in the invisible chat can give you all like a big clap and all the, the little like festive emojis, but you all are awesome. And I really think your work is terrific. So
same here.
Okay.
We're a fan of yours, big fan.
keep on keeping on. We're gonna keep rolling this boulder up the hill.
Let's do it.
Got
Thanks for
this.
joining us, Allison.
Okay, thanks y'all. Thanks for all the friends in the audience.
Bye.
Bye.